Good morning, everyone. My name is Peter Olivieri. I'm one of the pulmonary and critical care medicine attendings at the University of Maryland, Baltimore, Washington Medical Center. And we're going to be discussing implementing bedside percutaneous ultrasound gastrostomy in the critical care setting. By way of a few relevant disclosures, several months after our group had adopted performing this procedure, we became involved in an NIH-funded study which is listed here. And the SCCM educational session is sponsored by Coaptech, which is the company that makes the supplies for this procedure. So here's the outline. We're going to discuss the current options for gastrostomy overall, the various types. And we're going to specifically focus in on the type of gastrostomy that I'm talking about, which is percutaneous ultrasound gastrostomy. We're going to go over how this can be implemented and how we implemented it in our center in the ICU setting, as well as some issues related to cost, reimbursement, and some of the early outcomes and milestones that we've observed. So as this audience knows very well, the current options for gastrostomy tube placement include percutaneous endoscopic gastrostomy, or PEG, percutaneous radiographic gastrostomy, which is often done by interventional radiologists, various types of surgical feeding tube placement, including open gastrostomy, and now percutaneous ultrasound gastrostomy, which is what we're going to be focusing on today. And prior to 2020 at our center, most G-tubes were placed by either gastroenterologists or surgeons, as well as interventional radiologists. And during this year, we implemented percutaneous ultrasound gastrostomy, or PUG, in an effort to streamline our process in the ICU, since many of our patients require tracheostomy and G-tube placement. And this gives an idea of why someone would want to start doing this. So as many critical care providers know, when you have a patient in the ICU who requires a G-tube, it can be a little bit complicated. You have to, of course, get consent from the family. You usually have to consult someone like a surgeon or gastroenterologist. You have to find time for the patient to be moved down to the procedure suite. Anesthesiology has to get involved. Various techs and obviously the proceduralists have to meet up in this location outside of the ICU to perform the procedure before the patient can be then transported back to the ICU. And the paradigm here with PUG is that this is a gastrostomy that can be performed at the bedside in the intensive care unit by the same team of critical care providers that are already taking care of the patient in the ICU, without moving the patient, and in an effort to also maintain continuity of care. This slide just gives you an idea of some of the changes that we've seen as we've implemented this procedure in our center. And the top row in the slide actually is just a very small sample of 23 of the initial cases that we performed in the first couple months of starting this procedure. And it just gives you a sense that once we started doing bedside PUGs, the time to gastrostomy from the time we decided a gastrostomy was needed until the tube was actually in place was shortened quite a bit. And that was a small early sample. Since then, up to this point, we've now done more than 60 PUGs at our center. And the second and third row in the table are more up to date. We, at this point, have 5 critical care physicians who are credentialed to perform the procedure at our center. And this is just going to give you a brief overview of what the procedure actually looks like. You can see some of the tools that are used, including an external magnet, which is used to get this balloon, which is inserted into the mouth, which has a magnetic tip, to get apposition with the gastric wall and the anterior abdominal wall. And this familiar guide wire is used in most of the Seldinger type procedures that critical care providers are already familiar with. This particular video is in an interventional radiology suite, which is obviously not what we're talking about today. I'll show you some later pictures of a case that we did in our ICU. But what you can see here is that there is actually a tube that's inserted into the mouth, which has a magnet at its tip. And then the operator at the abdomen uses this other external magnet to pull up the internal magnet so that there is apposition between the anterior gastric wall and the anterior abdominal wall, so that fluid can be injected into the balloon and visualized with ultrasound from the outside. And then, in a way that is very familiar to critical care providers, the Seldinger technique is used to actually cannulate this fluid-filled balloon from the outside with a needle so that a guide wire can be fed into the balloon. And it's very similar to most of the other ultrasound guided procedures we do, such as cannulation of an internal jugular vein. You actually aspirate the fluid into the syringe, and then the guide wire is fed into the needle. The guide wire actually enters the fluid-filled balloon, and I'll show you later that when the wire enters the fluid-filled balloon, it coils, which actually causes mechanical coupling of the wire and the balloon, so that as the balloon catheter is extracted from the mouth, it actually pulls the wire up out of the mouth because the balloon and the wire are mechanically coupled. The wire can then be cut so that a gastrostomy tube can be fed over the wire, and this will ultimately emerge from the anterior abdominal wall, and by pulling on the tube, it dilates the tract, and then the gastrostomy tube is in place. So here are the indications and contraindications for PUG. And these, when the device was approved by the FDA, these were the indications that were approved. Largely, it's the same as PEG and IR-guided G-tube placement. You do have to be cognizant of things like ICDs, which might be sensitive to the external magnet, which is quite strong. The age is greater than or equal to 21 years. The BMI range that was approved was 20 to 30. And the track depth from stomach to skin that was approved by the FDA was 4.5 centimeters on CT scan. As our group got more comfortable with performing this procedure, we have now done many cases in patients that may be outside of these initial FDA indications. For instance, we've done patients with BMIs as high as 55 and track depths as deep as 6.5 centimeters. Now we're going to go into a little more detail on the steps of the procedure, and this is just an overview of the materials that are gathered ahead of time on a sterile table. We typically do use sterile saline that we dye blue. You can see the bowl in the lower right-hand corner, and the reason for this is that when we aspirate fluid from the balloon with the needle, we want to be able to confirm that the fluid that we're aspirating into the syringe is in fact fluid from the balloon as opposed to some other bodily fluid. So one of the first steps is, and I should mention that there are typically two operators involved here, one at the head of the bed and one at the abdomen. So the operator at the head of the bed will first insert the catheter that actually has the balloon at the tip that has a magnet in it. And that is inserted into the mouth. Most patients have a NG tube in place or an OG tube prior to the procedure, and gastric insufflation using medical air can be used to insufflate the stomach. This is not always required though, and this is something that we got a better sense of as we did more of this procedure. We actually often are able to do it without insufflation, but sometimes it can improve visualization of the balloon. Once the catheter is in place, the internal guide is removed from the catheter and the external magnet is placed on the outside of the patient. And this brings the internal magnet, which is at the tip of the catheter inside the stomach, into contact with the anterior abdominal wall. And the operator at the head of the bed then fills the balloon with the dyed fluid so that the operator at the abdomen can use an ultrasound to visualize the fluid-filled balloon and cannulate it with a needle and syringe. And you can see the flashback of blue liquid in the syringe there. And this is showing you an example of an actual case. So the interesting point here is that one of the advantages to PUG as opposed to other types of gastrostomy is that with ultrasound, just like with many of the other applications of point of care ultrasound, not only can we visualize the balloon to do this procedure, but we can also visualize other relevant anatomic structures in the area to help reduce the likelihood of a complication. So in this particular example on the left-hand side, you can see the fluid-filled balloon, which is this hypoechoic or anechoic structure with the internal catheter that you can see kind of in the middle of the screen. And then as you can see, just to the right of that is actually the liver. And in fact, the liver edge actually overlies the balloon to some extent. So this would not be a safe time to place the needle, obviously, because you could inadvertently place the needle through the edge of the liver. And this is something that you might not appreciate if you were doing this procedure endoscopically or with fluoroscopy. So during that case, what we were actually able to do then is by manipulating the external magnet on the outside of the body, we can actually use that to adjust the position of the internal balloon. Because as you move the external magnet on the body surface, it will drag the internal balloon with it. And as you can see on the right-hand side, this adjustment allowed us to get away from the liver, and we were able to safely cannulate the balloon and complete the procedure without a complication. So once you cannulate the balloon, you will detach the syringe from the needle and feed the pigtail guide wire into the needle, again, very similarly to many other Seldinger techniques. You will then deflate the balloon from the head of the bed by withdrawing the fluid and obviously remove the needle from the body so that only the guide wire is now in place. And you can then take the external magnet off of the patient. And the key point here is that when you do this, the balloon and the pigtail guide wire actually become mechanically coupled. And this allows the provider to actually withdraw the catheter from the mouth, which will actually pull the guide wire from the stomach up the esophagus and out the mouth. And once you do that, you can actually cut the pigtail off of the guide wire at the head of the bed and feed a gastrostomy tube over the guide wire at the head of the bed so that the gastrostomy tube can then be pulled out of the abdominal wall so that the gastrostomy procedure can be completed. And a tapered tip auto-dilating push gastrostomy tube is typically used, which is the same type of tube that is used in PEG. And you can see on the left-hand side there how the guide wire becomes mechanically coupled to the balloon. When the balloon is deflated, it grabs the pigtail so that as you withdraw the catheter from the mouth, it will hold the pigtail guide wire and pull it up the esophagus. So we're going to talk a little bit about how you can actually implement this procedure at your clinical site and how we did it if it's not something that's currently being done. So just to give you a little background on our hospital, it's a 285-bed academic affiliated hospital in the Baltimore, DC metro area. And of course, these numbers are before the COVID-19 pandemic, but our baseline is that we have a 24-bed ICU and a 12-bed IMC and a 25-member team, which includes a large number of advanced practice practitioners. And we already had a strong bedside percutaneous tracheostomy program that we were leading at the time. And that was part of why we wanted to start PUG, was that we were doing so many percutaneous trachs, and we wanted to be able to do our own gastrostomy tubes so that patients could limit delays and improve safety, hopefully. So you might wonder, well, how am I going to get started with this and actually get trained to do this procedure that I haven't done before? And there are really a number of options. There are a few CME courses that are offered, which utilize either cadavers or phantoms. There's one in Las Vegas, which is sponsored by CoAptech, and there's one in Baltimore, which is sponsored by the University of Maryland. And the first one uses primarily phantoms, and the Baltimore one, it relies on cadavers. There are also other options for how the company can actually work with you to work with your center, depending on what works for you to provide training either on site or virtually. So obviously, just like any other new procedure in your center, you have to discuss it with the relevant leaders. And in this case, I think it also makes a lot of sense to have a discussion with other providers that are currently performing gastrostomy, which might include gastroenterology, interventional radiology, and surgery. Our experience, and of course, this is only what we can only speak from our own experience at our center, but there really didn't seem to be much of a political issue at all, because the providers that were previously doing gastrostomy really were never really too thrilled to be doing them on critically ill patients anyway. And so they were, for the most part, more than happy to allow us to go ahead and do our own gastrostomy procedures. So in terms of credentialing, some of our physicians were trained actually by CoAPTech, but it was through the University of Maryland program on cadavers. And once we had adequate training with the cadavers, we were able to start doing some live cases. And then those of us that became credentialed were able to train our other colleagues and proctor them as they started to do their first live cases. Of course, that's going to vary by hospital in terms of what the specific requirements are for credentialing. And in terms of implementation, the company CoAPTech is available to provide a lot of support as you start to do your first several cases. And this can be done either in person or remotely. Once you start going with this and you feel like you're comfortable with the procedure, you start to turn your attention toward how you can actually streamline the process. Because if your center is anything like ours, and especially now with the pandemic, there are actually a large number of tracheostomy procedures that need to be done, and most of these patients need a gastrostomy. So obviously it behooves us to be efficient. So this image on the right-hand side shows an example of a procedure cart that we use that has all the equipment stocked ahead of time for both the percutaneous tracheostomy and the PUG, so that these can be done efficiently without a whole lot of setup time. And there's some information here that you can review just to give you some ballpark numbers in terms of cost. In terms of reimbursement, there is now a CPT code for PUG that was recently approved by the AMA, and reimbursement is expected to be similar to other gastrostomy procedures. So I should define this term TPUG. So this is the term we use for a combined procedure, which includes percutaneous dilatational tracheostomy and PUG done at the same time with the same sedation by the same team, all at the bedside as a combined procedure. And at this point, this is really our standard of care for patients in the critical care setting who require a tracheostomy and gastrostomy. So the reason that we think this makes sense is due to the fact that we think this is associated with improved patient safety, decreased need to transport the patient, and reduced cost and length of stay. And there's a paper referenced here, which was done in a neuro ICU population in 2017 by Dr. Nobleza et al., where it was suggested that doing tracheostomy and gastrostomy as a combined procedure may result in significant decrease in ICU length of stay and a significant reduction in cost. So when we do TPUG, once again, this is done under a single instance of sedation. We typically do the tracheostomy first, followed by gastrostomy afterward. And this is just giving you an idea of how complicated things can be when you're trying to coordinate both a tracheostomy and a gastrostomy for a patient who is currently in the ICU. And that's represented on the left-hand side, because in some instances, the gastrostomy and the tracheostomy may be done by separate providers. You might have a gastroenterologist doing one and a surgeon doing the other, or ENT. So it can get rather complicated in terms of the number of people that are involved, the number of times the patient needs to get transported, the number of sedation sessions that are required, cost, et cetera. And when this is compared with the TPUG model, everything can be done with one sedation, with one team, without moving the patient at the bedside in the intensive care unit, and much more quickly. Often within an hour's time, both procedures are complete. And we did publish a abstract at CHEST recently that described the protocol that we used for TPUG in the COVID-19 pandemic. And this was really early in the pandemic when things were a little less clear in terms of what PPE was needed and what types of aerosol generating procedures were safe and whether providers were going to be at risk and were going to get sick from doing these procedures. So we created this protocol, and the tenets of it were enhanced provider PPE, minimizing team size, and minimizing aerosolization. And at the time, we were pretty much exclusively using PAPRs during the procedure. We've since moved on to a number of other respirators, which from the literature we have seem to be equivalent to PAPRs for protecting against COVID-19, such as elastomeric masks. But at the time we were using PAPRs, and we minimized the team size by including only 2 critical care providers and a respiratory therapist for the trach, and then just 2 critical care providers in the room only for the gastrostomy part. The RT would leave the room at that time. And we didn't necessarily need a nurse in the room. We would often do our own sedation, and the nurse would be outside the room monitoring the vitals and would be available as an extra set of hands if we needed things to be handed into the room. But the purpose of this was just to try to get to the minimal necessary team size since we were doing an aerosol generating procedure. And we actually made some modifications to the procedure itself to try to minimize aerosolization. So this is during the tracheostomy, and you might notice if you look at the picture on the left-hand side, the ventilator is on standby. So we instituted an apneic, a couple of apneic periods actually during tracheostomy, where we would actually turn the ventilator off during the parts of the procedure that we thought were the highest risk for aerosolization, including the bronchoscopy and the part where the trachea is dilated. And then we also minimized gastric insufflation for the PUG portion of the procedure. And happy to report that no member of our team ever got sick with COVID-19, and we actually all had our antibodies tested and we were all negative. And this was, of course, before vaccination was available. So the point is, you can implement local protocols to modify the procedure as necessary to do it safely, even in the setting of the pandemic. And now, having doing PUG for about a year, it has become the standard of care at our center for gastrostomy in the ICU population. We've successfully done over 60 PUGs during 2020. Regarding complications, these are very similar to what you would expect for any gastrostomy procedure. The most common thing is inability to complete the procedure due to patient anatomy. And we don't have data on exactly how often this happens, but I would estimate it's probably on the order of about 10%. So the vast majority of the time, this procedure can be completed without any problem. But other things that we've seen include pneumoperitoneum. We had one case of inadvertent placement of the tube through the transverse mesocolon. So not the actual colon, but the thin membrane that suspends the colon. And we only found out about this later because the patient required surgery for a different reason. But this did not cause any injury to the bowel. And from talking to other providers, such as surgeons and gastroenterologists, this is actually a relatively common thing that happens during other types of G-tube placement. We did have 2 cases of peritonitis that I know of as well. So the average time from the decision that the patient needs a gastrostomy to the time that the PUG is placed is less than 1 day. It's typically on the same day, or sometimes it might be more than that if the family needs to think about it for a while to provide consent, but we can typically do it on the same day. And we now have 5 physicians who are credentialed to perform this procedure. So here are some milestones that we've had at our center in the past year. We were the first in the world to do this procedure in the intensive care unit by the ICU team, first in the world to do a TPUG, or combined tracheostomy PUG procedure. We have the record for the shortest PUG, which was done in 8 minutes, the shortest TPUG, which is about 20 minutes, greatest depth from skin surface to stomach, which was 6.5 centimeters, and the largest BMI, which was 55. And you can see an example of a patient that we successfully did the PUG on in this picture on the right-hand side. And we do, whenever we need to, we can do this procedure, whether it's weekend, weekday, day, or night to get it done as expeditiously as possible. So I just wanted to take a moment to acknowledge the multidisciplinary team that made this possible. And just like many other things in critical care, this is part of what makes it fun, is that we have so many people that we work together with. This involved respiratory therapists, physicians, APPs, nurses, as well as various techs. And I also wanted to acknowledge some of our research partners who have been integral in allowing us to start to study this procedure. We will be available to take your questions and are looking forward to talking to you. Thank you very much.